We'll go to the next session and we'll come back once things settle, because I think this internet connectivity is also a problem. So the next topic is by Dr. PMS Haritha, vascular closure devices need of I request Dr. Haritha to come and start the proceedings. I think Dr. Haritha needs no introduction. She was everything behind this conference going on so beautifully. Over to her.
Thank you, sir. Sorry for the inconvenience that has happened. My topic is on vascular closure devices. So, which many of the centers now they have started using these closure devices. Recently, since 3-4 months, we started using ProGlide after seeing the TAVR cases and EVAR cases. Next. So why should we go for these vascular closure devices? So most of the times we do see complications post-procedure when we opt for the femoral access. So the commonest thing being the hematomas. So, and retroperitoneal hematomas, AV fistula. We have seen 2 cases of AV fistula, thrombosis and rarely infection. We have to go for surgeries also. Next. Next slide. So, it increases the hospital stay. Patient may require blood transfusion post-procedure, which can increase the rates of stent thrombosis. Patient needs surgical repair, and there can be discomfort and increasing nursing time, and so many staff should be involved for the procedures. Next. So for whom we have to opt for these vascular closure devices? So these are all female patients, obese patients, those who have the risk of hypertension, elderly patients, patients with AR, and those who are having coagulopathy, and patients with presence of distal peripheral vascular disease, and those with CKD, and those who are on anticoagulants and antiplatelets. So why we are not going for these vascular closure devices is because of the cost, predominantly because of the cost, and routinely they are used to do the manual compression. Next. And we do feel that there is the procedures are complicated and it is very difficult to go, and there is a big learning curve for these closure devices. So these are the goals. So early ambulation is the first goal. Next. So what are the methods of hemostasis? So there are 2 types of vascular closure devices, active closure and passive closure. Next. Manual compression, we all know about it very well. So passive closure, it increases, it assists and enhances the coagulation. And there are some techniques of putting pressure and clamps, and procoagulant devices are designed. Active closure is with closure with suture or clips. Next. So these are the hemostasis methods: manual compression, assisted manual compression, hemostatic patches. They are available now. We do use sometimes, but they are very superficial, not very much useful. And now the recent trend is the vascular closure devices. The device is inserted into the body of the at the femoral arteriotomy site, and there they deliver either the material or the sutures. Next. Next. So this is manual compression. Next. So what are all the prerequisites to use the vascular closure devices? So the puncture should be below the inferior epigastric artery and above the profunda femoris. So it should be exactly at the common femoral artery in the upper 2/3 of the femoral head. So there should be an ideal puncture site in the common femoral artery we should not do the Seldinger technique, and there should not be calcification around the artery, and it should not be a high arteriotomy or a low arteriotomy, and the diameter of the common femoral artery should be more than 4 millimeters. And before doing closure device, using the closure device, we have to do the arteriogram and delineate whether it is in the common femoral artery or not. Next. So these are the contraindications for using a vascular closure device. Next. So where we have to use these closure devices means there is a large scope in the interventional cardiology and interventional radiology while doing EVA and neuroradiology, early ambulation of the patient and during vascular surgery. Next. So these are the devices. So the first device is a passive closure device. It is an extravascular device, and there is a small disc, collapsible disc. While withdrawing the sheath, this disc adheres to the arterial wall, and after we ensure that it is completely adhered to the wall, we release the thrombogenic resorbable collagen patch. So we have to give a few minutes of manual compression after the deployment. Next. So MINS is it is apparently a very easy procedure. Through the sheath we have to keep this device, and while removing the sheath we have to inflate the distal balloon. The balloon will occlude the arteriotomy site, and through the sheath we will inject this material which will slowly resorb over time. Next. For these procedures, there is no need to exchange the sheath. So this is same. Next. So these are the vascular closure devices. Angioseal. Angioseal, it comes in 6 French and 8 French sheaths. Next. So it is used for active closure to attain the rapid hemostasis, and we can mobilize the patient after 1 hour. Next. So there are studies which say that the risk with these devices is less and the primary endpoints are significantly met with. Next. Next. So these are the steps of deployment in angioseal, wherein we will deliver. We have to locate the arteriotomy site, and we have to introduce the sheath of angioseal, and we have to anchor the arteriotomy site. Later we have to release the collagen plug, and the small thread, the residual suture, we have to cut it off. Next. So it gets absorbed in 90 days. Next. So as it is in all other patients, this is also useful in the high-risk subset. Next. So in this, there is both an anchor and a collagen plug so that it adheres tightly to the arteriotomy site and it narrows the arteriotomy site. Next. So the next one which we commonly use is the ProGlide. It is a perclose technique. So in ProGlide there are 2 needles that will insert into the foot pads of the device post-procedure. Next. While doing the procedure, there are 4 steps. We have to locate the artery, keep the ProGlide accurately into the artery, and then we have to introduce the needles into the artery, and they will go into the foot pads. While we withdraw the device, we will introduce the needles into the artery, and there are threads, 2 threads that come out of the device, and we have to, that creates a knot inside the artery and decreases the size of the arteriotomy. Next. So star close is one more device. Next. So the complications with ProGlide and angioceal and star close. Each one has its own advantages and disadvantages. Next. So each one is a different entity, de novo, like they are not having, one is with this is a introducer sheath, wherein the sheath is having a small intestinal submucosa of the pig that lodges at the site of the arteriotomy, and while removing the sheath, it gets hugged onto the arteriotomy site. Next. So in summary, patients considered for deployment of VCD should undergo a femoral angiogram before doing the VCD. Use of VCD is reasonable to achieve faster hemostasis, shorter duration of stay of the patient and improves the patient comfort. But still we have to weigh against the risk of increased complications and also the cost of the procedure. Thank you.
What is the general expenditure for this type of devices? What is the best device for us?
Sir, ProGlide we are using, sir.
Regularly we are using?
Yes, sir. It is coming around 18,000.
18? Yes. So only for the TAVR you are using?
TAVR and EVA, sir. Some PCI cases who are obese, we are using the femoral artery, sir. We are using.
So that is very user-friendly, the cheapest.
There is some learning curve, sir. It is done means it is very easy.
The training is given by the company.
On table itself, bleeding will stop and it is, yes sir, company guys.
Madam, are there any complications of these devices?
Now I didn't see any, but sometimes we may fail in doing the procedure. Like that bleeding may not stop, we have to go for manual compression.
One of my colleagues.
No need, sir. On table itself, the bleeding will arrest.
We have an angioceal that was one of our colleagues was using it in his previous session. If we apply more pressure after closing the vessel with the device, if we apply compression on this, it will normalize the state.
There are case reports that pad is there in the angioceal that has embolized distally into the popliteal artery.
I have used angioceal, I have used plenty, though we are using 8 French and 7 French. And it's fairly simple, and that compression you should not push too hard. Nicely stops, immediately it stops, and that thread is there, you can keep it till you are very sure nothing will happen, then you can cut it. Otherwise you have that control on that. You cannot pull it back too much hard, also it comes off. So it should sit on that surface. Little technical details. But once we started using radial and we stopped using that, then even femoral also daytime angios we used to use fiber catheter and all for that after 3-4 hours without any angioceal also we started here. But nowadays because of interventions, bigger catheters, those less definitely. Old people, calcified artery, whatever number, then they will not have. Those are the areas, otherwise very limited use nowadays.
Commonly used vascular occlusive devices, which is cost-effective, is angioceal. And angioceal is very user-friendly, number one. And whenever you are using 8 French sheath for complex interventions, or 7 French sheath, you can close and you can achieve very nice hemostasis. And most important is, as Madam beautifully depicted, the common femoral artery is the one which between the anatomical points of inferior epigastric artery and profunda bifurcation point. This is the thing. I think actually the traditional teaching of crease, below the crease, puncture, all these are the nonsense actually, to be frank. So that is for learning purpose. But you have to do under fluoroscopy whenever we are for 5 French sheath, okay, it is immaterial whether you puncture superficial femoral or profunda late femoral. immaterial. But whenever you want to select a complex with a large code sheet, minimum 7 to then above 7 plus, then we have to see the fluoroscopic guidance, and femoral head is our most important. And recently we are practicing ultrasound guided micropunctioning technique, where it will almost totally negate the vascular complications of the femoral vessels, which we are practicing now. And of course, a little bit cost is 12,000 to 15,000 extra. So angioplasty is cost effective, 12,000. Next, propelite. For all the structural heart diseases, we are using propelite. 2 propelites are minimally needed. One is at 10 o'clock and one is 2 o'clock position. And whereas for the 7 French, 8 French, single propelite at 12 o'clock position, always fluoroscopic guided, common femoral artery. Femoral head is the one which you have to aim at, so that you will totally avoid or prevent the vascular complications. These 2 are the common devices usually we are practicing.
Yeah, we have performed almost 9 to 10 cases. See, if you are not comfortable with the ultrasound, what we do is from the left femoral artery, we'll put pigtail in the femoral head, and with the guidance we use it to puncture this one.
And you are puncturing 2 punctures.
Yeah, for TAVR we require 2 punctures. For TAVR we require 2, and basic technique is it should be below the inferior epigastric, it should be above the superficial femoral. And one more thing, for whenever we are using for 7 French, 8 French, even for TAVR also, even one problade will arrest the bleeding sometimes. Without checking after one problade, if you not the second problade, it will result in the femoral artery narrowing. This is very, very important. And once the second, you ligate the femoral artery with the second problade, again you will develop the femoral artery obstruction. So after problade, again you check if the bleeding is stopped and do the contralateral angio, and there is even minor residual stress of the femoral artery, then one problade will have, and second problade without not, we can just take it out from the right.
Any other from the audience? Sharma?
Yeah, I've used multiple times this angiocenes, especially carotid stenting to put a large and 8 French. The most important, it's very user friendly. You can make the person walk, even after 8 French sheet, 15 minutes or 20 minutes on the table, you can walk out. As what somebody has pointed out, don't press it too much. That's the most important thing. Because we are anxious that you have to keep pressing, we are used to that. You just angiocene it and then give it 15 minutes, and then the person can walk out. The important step is that, again I repeat, that don't press too much, because there will be embolization of this ankle to the popliteal artery. That's the only precaution you have to take. Otherwise, it's really user friendly, and especially as what he says, if you are using more than 7 or 8, then it's really user friendly. And unfortunately, angiocene doesn't come beyond 8, as Somnath is saying. Then you have to use problade. Problade requires a little bit of training, but angiocene is very, very simple. Once you see it, you can do it.
Okay, as the time is over, we will conclude this session. So thank you very much for everybody and for the speakers for an excellent discussion. Thank you very much.